So we'll make a start. I hope you all enjoyed your lunch. And if you're joining us from the live stream, I hope you're still eating your lunch and walking around and drinking tea and having all these advantages that we don't have, being crammed into a very small, crowded room, very popular room in St. Paul's. You're very welcome. We'll be taking questions from the people joining online through the miracle of technology when we get to that point in the proceedings. This session is about technology, and it's about how it's changing health and healthcare for good and bad. And I say for good and bad because in this area, as in so many areas in our lives, we seem to be stuck between two opposing narratives. There is the techno-utopian camp, where technology is going to produce a more personalized, more connected, more empowered individuals and healthcare system. And there's the very dystopian future where decisions about our lives are going to be made by machines, by algorithms. These will determine which jobs we get, which treatments we get, whether we refer to surgery or not. And technology in this scenario will lead to people being very disenfranchised. And of course, the future is going to be something else entirely. And to understand what that might be and to shape it, different communities need to come together. And that is very much the philosophy behind this particular session. We wanted to bring together different perspectives to talk about how to shape the impact of technology to make sure that we reap the benefits and manage some of the risks associated with it. What about the NHS? Many of you will have read Matt Hancock's vision for technology, which was published, I think, just a little before Christmas. In the document, he writes about the need to do the basics well within the NHS, the need to get good IT, the need to get good online services, which he argues will help to improve patient outcomes, to reduce the frustration that staff feel, and also potentially to save money which could be reinvested in frontline services. The vision also talks about new technologies, such as artificial intelligence, which might help doctors to make more informed diagnoses of things like lung cancer or eye disease, and to make more informed recommendations for treatments. And their vision is about more personalized and more predictive healthcare. This morning, we heard from Simon Stevens about the long-term plan, where technology was positioned as one of the three enablers alongside workforce and capital investment. The long-term plan, as I'm sure you know, is full of ideas and initiatives about technology, including the NHS app, which is about making it easier for people to access healthcare, and a commitment that all people should be able to receive digital-first primary care, which could be delivered through video conferences, for example. There's also a lot of work in the long-term plan in terms of the underlying infrastructure, for example, and a continuation of the Global Digital Exemplar Programme, which, as you know, is about continuing to implement electronic health records. We also have Nhs X, just recently announced, which is aiming to accelerate the adoption of technology across the NHS, mainly through, to begin with, open standards, which aim to make sure that the NHS can use technologies that's being developed elsewhere. And it's also about giving developers a clearer idea about what are the ways into the NHS from a technical perspective. Nhs X may also challenge the culture of adoption of technologies within the NHS, talking about a more agile and responsive approach. We've got the Code of Conduct, which is being developed by Indra Joshi, who's speaking later on today with Jess Morley, which is beginning to give developers a new framework to help them think about what impacts they might be having, and so on and so on. There's a very crowded innovation landscape. And one of the big challenges in this area is just that it's just very hard to know what's going on. What we thought we'd do in this session is to explore some of the more detailed, more specific challenges. And we have three excellent speakers who I will hand over to just in a moment. To begin with, we'll hear from Maddie, who you'll hear her story in a moment, but I think her story should really, make all of us think quite differently about our jobs and about how we are enabling patients and carers to lead innovation, how we are drawing more on the expertise and skills and drive of that group. We're very honoured to have Maddie here today. We will also hear from a practitioner, and as we know, actually one of my colleagues, Tom Hardy, wrote a blog just last week about some of the challenges that practitioners face when it comes to implementing technology, mainly about time. It's about how to make sure we put time into changing the workflows to allow technology to be implemented, redesign care pathways. We'll hear about Ramani. Ramani, I'm sure, is very pushed for time, yet has amazingly managed to write a blog today already, setting out some of your thoughts, which is testimony to how organized you are. So we're very happy to hear from you. And then finally, we'll hear from Neil, really about the data, which is underpinning so many of these new technologies. The NHS has the best data in the world in theory, because we have had electronic health records in primary care since the 80s. We have a universal health system. We have an NHS number, but the data are very, very fragmented. And how do we bring the data together to enable it to be used for innovation? And that's one of the challenges that Neil will be talking about in a second. Just before I hand over to Maddie, I did want to really bring in the topic of inequalities into the discussion, following on from the excellent session before the break, where we had those quizzes, and we participated in that experiment to help us understand the scope of inequalities in the NHS. There are at least 3 ways I've just written down here in which technology could help or worsen inequalities. You'll have many other ideas as well, and I just wanted us to bring that into the discussion. My ideas are around what does digital exclusion mean here? We heard just last week from the Social Market Foundation that 1/4 of people with a registered disability are offline. What does that mean for this agenda? What does it mean if not everybody receives the education that they need in order to participate in some of these new approaches? What are the implications of multi-channel access? We are focusing, I think, in terms of national policy, on developing new channels to access healthcare which are digital. But what about some of the other channels which are not digital? And if we think about what's happened to post offices or banks, what does that say potentially about the NHS? And then finally, what about the inequalities and how we use data? Most of the data research is happening in London and a few other regions of the country, as the report filed by Future Care Capital showed yesterday. You'll have many other thoughts and ideas on this topic in the room and online. We'll make sure we have plenty of time to hear your questions and your thoughts, so please be thinking about those and prepared to contribute. To begin with, though, I'd like to hand over to Maddie. Thank you.
It's a pleasure to be here. Thanks very much. So on the 4th of November 2015, our beautiful young son became one of the 30,000 children in the UK that was diagnosed with type 1 diabetes, a life-threatening condition. We had amazing training in hospital, and we had a fantastic team in Leeds. But when we got out of hospital, our extended family confided in us, and so did our friends and then the nursery, that they were no longer comfortable looking after our son because they hadn't had the excellent training that we'd had in hospital. I was a teacher, and my partner had a video production company, and I also used to run an art centre. At this stage, we were independent people, working people, and we felt a huge loss of independence. So, fast forward a couple of months into our diagnosis, and we just felt that we really needed to use our experience to improve the services for others after us. So we tentatively approached Leeds Children's Hospital, who were lovely, and we said, please, can we just film your essential training that you do in hospital and put it online so families like ours could review our training and teach our friends and family so that we feel less isolated. We were so lucky that we had Leeds as a team, and they're a gold standard under Dr. Fiona Campbell, who's the driving force behind the Children and Young People's Diabetes Network as well. So, Leeds really fully supported us during this process, and together we created a multi-award-winning, patient-led yet clinically approved video training platform over the last couple of years. It's now freely available to anyone who needs it 24/7, and it's available in 99 languages. So less than 3 years ago, DigiBeat was just an idea, but I'm really pleased to say that fast forward those 3 years and we realised that it was an idea that together we actually nurtured. So how do we go about creating and developing a patient-centred model for self-management? Well, we listened to each other and we worked together. We heard other clinical teams, and I heard, when I was presenting and out and about, people talk about what patient-centred care actually means. And we started thinking, what does it mean? For us, it wasn't a tick box, and it wasn't in an hour in the company of someone else's solution, but it was about our trusted relationship, an extended network of people supporting our NHS in schools, in the communities, and in homes. It was about creating enlightened workplaces and keeping those with type 1 diabetes motivated and supported and feeling supported in the community. So we've co-designed with hundreds of families now and presented to healthcare professionals up and down the country. And I've seen and read and heard lots about the variances in care and supportive technologies that are around, and also the work that's been done through the amazing Diabetes QI project. However, there are still 70% of young people who are not managing their diabetes well. So I feel that we must look at every opportunity to improve that education and quality of life for these young people who are really struggling every single day. So in Leeds Children's Hospital, for example, there's about 50 hours of clinical contact time support per patient annually. That leaves about 99% of self-management and care happening at home and in the community, where people are really not very skilled at doing it. So all this available time, we feel, is a massive opportunity for those community partnerships. It's an opportunity to wrap care around those young people and to create better habits. Patients and families using DigiBeat report that they think it saves them contact with their clinical team, but there's so much more we need to do to put that much needed nurse in their pocket that they so crave when they talk to us. So the reality of any patient innovator in the NHS that I found is that it's very difficult. Scaling services, digital services, within the kind of landscape of so many different organisations. Some professionals doubted our intentions and felt that we were a threat to current clinical pathways, while some patients, because we got organised, felt that we were already being funded by the NHS and we were kind of part of that. The truth is, we were neither. We're a social enterprise. And as we set sail into our third year now of DigiBeat's patient-led, clinically approved model, we feel finally the stars are aligning and we feel so much better understood by the system that we've set out to help. We hear from clinicians thinking about digital and using digital to extend care. There's a huge responsibility of building evidence models, clinical safety, funding, struggling with adoption, interoperability, duplication, procurement challenges, etc., alongside their day job. But what if these responsibilities could be shared? What if we could scale assistive solutions championed by patients? How could these new communities expand or even transform care instead of just facing these constant challenges? In a world of Uber and instant banking, we can't really afford to wait for our healthcare, and there are movements now of patients that are trying desperately to sort of solve these problems. So for patients and families, good care and advice needs to be accessible and available when we need it, 24/7. Good care is not just delivered in our 4 appointments a year, although we're very grateful for them, but it's at 3 a.m. when our son's blood sugars are yo-yoing and his ketones are going up and we're really quite scared and fatigued. Excellent care must be patient-led and clinically approved. One without the other just doesn't work. It must be scalable and on demand, and it starts with a trusted collaboration between the patient family and, of course, the expert team. Thank you for listening.
It's a tough act to follow. My name's Ramani. I'm a clinical doctor. I'm an anaesthetist, and I work in London. And I'm also interested in how we improve the quality of healthcare, and in particular perioperative care, so surgical healthcare. So one of my key interests is in how we assess patient risk before patients undergo major surgery. And the reason that it's important to try and assess patient risk is because, first of all, it enables us to plan the sort of care that we're going to give to patients. So if, for example, we think a patient is particularly high risk, if there's a choice of the type of operation they may have, we may go for the one that's less severe. And also we may choose to manage them slightly differently when they come into hospital. Like, for example, we might send them to an intensive care unit afterwards. The second and probably the more important reason, well, definitely the more important reason, is because through understanding what the patient's risk of an adverse outcome is, we can then work with the patient to help them understand what their risks are and come to a shared decision about how to proceed. Because sometimes surgery isn't the right option for that patient on that particular day, and there may be other things that they want to consider. But they can't do that unless they understand what their risks are, and also what the potential risks of not having surgery are. Now, when we start to think about how we assess risk, we can do it in a number of different ways. We can do what we might call the end of the bedogram, which is a doctor stands at the end of the bed and has a look and thinks, okay, and puts a number on a piece of paper, or says high, medium, or low. We can use calculators, and of course over the years, as our understanding of statistics has improved, we've moved away from simple scores that might rate a patient on a scale of 1 to 5 according to their risk, for example, to using complex calculators, which are much less complicated these days because of the advance of apps and computers. And you can put some numbers in relating to patient risk factors like age and weight and the type of surgery they're having and their comorbidities. And it chucks out a number at you, which will be, for example, the percentage risk of death within 30 days or a particular complication or so on. So let's call those risk models. And then another way that you can assess risk is by doing some really fancy stuff, by putting a patient on an exercise bike and formally assessing their fitness. And through measuring expired gases, looking at their ECG and a whole bunch of other things as they exercise to peak exercise, you can get an estimate of their cardiorespiratory fitness and therefore their chances of having an adverse outcome after surgery, because the two are very clearly related. And that's called cardiopulmonary exercise testing. Now, as you would imagine, as you go from the end of the bedogram through to the risk calculator, through to the cardiopulmonary exercise test, the cost of doing those things goes up. The feasibility of those things potentially goes down. Now, one of the other reasons that we have to assess risk in patients is because there's actually a legal imperative to do that now. Since a case called the Nadine Montgomery case, doctors are legally required to give patients an individualized estimation of their risk, not just of death, but of materially important risks to them. So if a concert pianist is coming for a hand operation, you need to give them an estimate of whether or not they're going to be able to go back to playing the piano. So all of these methods are really good for trying to help you estimate what an individual patient risk might be. But how well have we adopted any of these technologies? Well, the end of the bedogram, we're not really sure how often people actually formally do that, because actually our compliance with writing down a patient's individualized risk before an operation is really poor, despite the legal precedent in this country. If we look at the adoption of risk calculators, even downloading apps of well-validated risk calculators in practice is actually not anywhere near as good as you would hope it would be. What's really, really interesting is that the anaesthetic community in general has really got excited about the idea of cardiopulmonary exercise testing. And I am not entirely sure why that is. There's good evidence to support the relationship between fitness and outcome, but there's good evidence to support the use of some of these risk calculators as well. And the risk calculators are basically free. and they're accessible to everyone in the same way that something like DigiBeat is. So why is it that we're going for the shiny, shiny gizmo? Can you guess? On a similar note, one of my PhD students has developed an app which is aimed at trying to reduce anxiety in children before they have surgery. It's a really terrific innovation, and it can be used in a virtual reality way as well. It's really cool. But we've decided that the right thing to do is to evaluate that intervention faithfully in order to make sure that there's just not just the tiniest risk that it would make anxiety worse in these children. And what's astonishing about this to me is that we're getting hospitals beating down our door to use the app without the evaluation because they want to adopt this because it sounds really cool. So I'm being interested in exploring some of these issues about what it is that, from a psychological perspective and a behavioural perspective, are the challenges, the barriers and the enablers to adopting innovation in the NHS. Thank you.
So my name is Neil Severe, so I'm Professor of Pathology at Great Ormond Street Hospital. I'm also the Chief Research Information Officer. So my interest is how can we make use of all of the data that in theory we are now generating, and we need to recognize that actually what we consider now as health data, so the data that's in your health record, will be insignificantly small compared to all of the rest of your health data in the future. Home monitoring, wearables, sensors, devices, etc. So I kind of came to this from a slightly circuitous route. I originally trained as an obstetrician, gynecologist, specializing in fetal medicine. I was interested in complications of pregnancy. I then trained in pathology specifically to be able to look at complications of pregnancy. And a lot of my research was on stillbirth and cot death. And one of the things we did at Great Ormond Street was say, when we're investigating stillbirth, there is guidelines from the Royal College of Pathologists about how that investigation should be done. What is the value of the various components of that investigation? And I thought, once we had done this on our own population, this should be easy to compare across the country, because surely everyone is doing it the same way, because there's guidelines. But it turns out that even though there's guidelines, there are no guidelines for how to record anything that you're doing. So almost every hospital still, throughout the country, writes down text. So there are large chunks of text, all in a different format. So almost every hospital where an investigation is done, the content might be the same, but in a different order, etc. So I started to get interested in how we could standardize data. Because if you started to standardize things, you don't have to do any more work, but you suddenly release potential value. Another example, Great Ormond Street is a very research-active hospital. We do about 1,200 clinical studies a year. And nearly all of those studies record various observations about the patients. And one of those, won't surprise you, is age. Now, you would think you can't get easier than age. Surely everyone's recording that the same. Well, no, I'm afraid, because some research studies, it will be age with a capital A. Some it will be called something completely different. Some it will be age in years, some age in weeks, some age in days. Some ages are from when the child was born. Some ages are from when the child should have been born if it was born at 24 weeks. The problem is, if you don't tell us what your age was, we have no idea what that data means, and we cannot reuse it. And this is a big kind of frustration of mine. And large research funders, whether it's in heart disease, cancer, child health, cannot merge the data from multiple studies, largely because the data has not been defined properly. So that's, for me, a huge thing we can do is to start to say, can we start to make what we do now in terms of data better before we start worrying about streaming data and wearables and devices, because otherwise it's just going to explode even worse. So that's a bit of background. One of the things we're doing at Great Ormond is we've got rid of 400 odd of our 450 clinical systems recently and replaced them with a single electronic patient record system. So essentially we now have one big proprietary locked-in data instead of lots of smaller ones, but that's a slightly easier issue to deal with. But what we recognized is that actually, however good your systems are for patient care and running the hospital, those systems will never be good for secondary use of the data because that's not what they're designed for. So you need some other system that allows you to easily take that data, de-identify it, and perform analysis, etc. on it. And one of the things that we've done recently, before we put the patient record in, was develop a digital research environment. So a place where you can bring data sets, push them into workspaces for researchers, and keep that data both secure, but also fully auditable about what analysis is done on the data. From that, one of the things that sort of developed was starting to think about what are the future sources of data. Now, they are likely to be from devices, for example. And we realized that whether it's an app from a patient, whether it's something from a tech company, it's really hard to test whether something is any good before it goes into healthcare. So a surgeon comes back from a conference and goes, I saw this augmented reality app, it's really good, we should get it. Should we get it? What is the process for evaluating that? Because we haven't nailed down those processes. So to just give you a very tangible example, many of you may have a voice assistant, I won't use a name, at home. And people have said to us, well, why don't you use those in hospitals? That would be so good because the nurses don't have to wash their hands, etc. And the concept is great. Imagine if you're on the intensive care unit, do you really want everyone saying, turn off the ventilator? And so who's going to authenticate that? Are we going to now use voice authentication? Are we now going to have different levels of control for who can say what in different scenarios? Are they going to interfere with each other? How many should we have? So that's just one simple example. And what we realized was it's almost impossible to test that because you've got tech over here and you've got a real hospital over here. So if you want to test something in theatres, you can't just shut a theatre for the day to test this thing. So we actually, to address that, realized you needed a place where you could bring together tech companies, computer scientists, clinicians, nurses, industry, and test those things with real doctors and nurses, but without real patients and with no clinical risk. So we set up a digital research and informatics unit, which is essentially a structure to try and do that, where you can actually say, you know what? Let's just try this thing and see if it's any good. Does the battery run out really quickly? What's the Bluetooth range? If it does work, how are we going to deal with that data? Whose job is it going to be to look at all of this data coming in from this thing now? Whose job is it going to be to look after these things? Because we don't have, in the NHS, people to do all of this. So for me, the whole concept is not just the data, that's the core bit, but even if we have the data, how do we actually deploy these kind of things across the NHS? If we have a new algorithm, everyone's excited about AI at the moment and developing an algorithm. And let's say you have a brilliant algorithm that does something, predicts something. That's very nice for your publication, but how do you get that into St Elsewhere Hospital and make it useful for patients? And how do you now upgrade that so that some of the nurses are not using version 2 and some using version 3 and some using version 1.5? That whole thing of how we manage technology in the NHS is something that we really haven't started considering yet and we need to be thinking about.
Thank you very much. So we're going to be relying on questions from the floor pretty soon, so I hope you've got some ready. But just before we do that, I just wanted to carry on the conversation, because we've been talking about this for a few weeks in the run-up to the event, and just try to build on that. One thing that's really struck me is that we're all innovators, we're wanting to use our skills to improve care. And I think we all recognise that there's a need to work with different groups. You know, we want to be working with data people, patients, docs, system leaders. but it can be quite hard to do that because of the way that the system is organised. And what are your reflections, or sort of what are the barriers to collaboration in this area? And Maddie, you might like to start.
Okay, so I think one of the barriers initially to collaboration probably is from a patient perspective, is firstly knowing who to collaborate with. So you've got your initial team, and then what else do you need to make that work, to make it clinically safe and to create those evaluations? And actually you don't know any of that anyway at the beginning. You only know that you wanted to do this because it makes a difference. So then it's kind of building that knowledge and that understanding. So I think the initial barrier is not so much about who to collaborate with, but knowing where those collaborations should lie. So, you know, I've been thinking for a while about a sort of like an innovation pathway for those kind of patient ideas and opportunities, so that people understand what's kind of needed from the beginning, so that you don't have a situation where you have something that's kind of rolling, that's happening before you realise it. You're kind of pervading the potential for it to be evaluated properly, at least if that's a conscious or conscious decision. Either way, then that's fine, but not necessarily if it's just a kind of an innovation that comes from a sort of a need, a guttural need, if you like. It can sometimes be difficult. So I think knowing who to collaborate with is the first barrier, and then after that, it's about building a really kind of strong, powerful team. So we were lucky at Leeds, because our first collaboration was with a kind of a really gold standard team who were recognised internationally for their work. So we had a stepping stone. But if you don't have that, it's probably finding the right kind of clinical team that are going to take on and actually be open and support and enable the innovation. And I think that could be a potential barrier to other patient leaders who have got this great idea. And I hear this actually through the networks and things. You hear people saying, I tried this, I went to the hospital, I said it'd be really good to have this, that, the other, but they said, no, we don't have time. And probably time is the huge barrier for everybody, isn't it? But so some form of like launch pad or innovation pathway would really help, I think.
I know you've been thinking quite a lot about the sort of beginning of the innovation process and how you bring people together around.
Yeah, and I think if I can sort of lead on from yours as well. I mean, in terms of the practical kind of barriers that we've seen and how you might be able to solve some of those, one of those is clearly around technical things. How can you stop multiple little apps collecting data on their own, which is one of the issues that is a plethora. So how can you link up that to your electronic patient record and then to your personal health record, etc.? And that is a very complicated task for many, which we can discuss for a long time, but I won't go into that now. There is also then the financial barrier. And to give you an example, if, for example, in Great Ormond Street, when patients come to see us, if they have an appointment at, say, 9 o'clock in the morning, lots of our patients are from all over the country, they often have to come down the night before. They have to stay in a hotel. They have to get someone else to look after other kids. It's a massive thing for maybe a couple of days. So there's a huge financial benefit to the country for example, us being able to do a video consultation. But the system at the moment means the hospital don't get paid for a video consultation, but they do get paid for an in-person consultation. So trying to encourage chief execs to change the system is very difficult from that perspective. And as we mentioned earlier, if you have an app that does something brilliant that saves money for your GP, the hospital don't see that as something that they see any benefit of doing, even though the system as a whole massively benefits. And we need a big shift to say we have to look at the whole system rather than just what each individual place is doing. Because that, for us, we really notice that as a big issue. The last thing, I guess, is nearly all of the stuff we've discussed today is no one's job in the NHS at the moment.
Yeah.
We don't have technical teams. We don't have app designers. We don't have people whose job is to do this, and we do need to. And I think what's going to happen is we're at the end, I think. We're at the end of the era where healthcare is what it was. As in, healthcare is something that the healthcare profession does to patients. That's going to massively, massively blur. And the whole concept of what do you need your doctor for is going to really change over time if you can start to interact in different ways. Because actually what you require then from different healthcare professionals is quite different. And therefore it may be much more valuable to be able to access someone live at night time than it is to be able to go and see them 2 weeks later. And it's those kind of things that the healthcare profession just doesn't get yet. It's still very much blinkered of this is what doctors do, this is what nurses do, and this is how we've always done it.
Do you think this is going to change your job?
Is this going to change my job? Oh, well, I'm not sure that my job will exist in 25, 30 years' time, not in the way that it does now, because technology will take over so much of what doctors do in general, what anaesthetists do in particular, what surgeons do currently, and so on and so forth. Going back to the question of barriers to collaboration and that sort of thing, I think, and barriers to progress, if you think about technology and getting it into the system, it's about development and implementation and evaluation, and we are getting better at it, but treating those as a series of steps as opposed to an all-in-one sort of parallel endeavour is a mistake. So when you're thinking through development, you have to be thinking about implementation. Before you're even implementing, you need to be thinking about evaluation. The money thing is really interesting. The way that the NHS works is so siloed at the moment. We're siloed between primary and secondary and social care. We're siloed between individual departments in hospitals. We're even siloed within in theatres. Surgeon A might do it this way and surgeon B might do it that way, and they have their different ways of their different preferences and so on and so forth. So I agree that the silos need to be broken down in order to help people understand the community benefit of bringing technology in and understanding that it's not just every person or group for themselves, it's about doing the right thing for the community as well as for the patient and as well. I think I'll stop there.
Thank you so much. What are the thoughts from the room? What have we missed? What questions do you have? Really happy you brought that up because I will do, sorry. So the question is about the regulatory approach for technology. And I think it's one of the questions that nobody has the answer to at the moment. There seem to be huge challenges here when it comes to regulation. And for me, one example of that is about algorithms, and particularly dynamic algorithms. So we know that the Google search engine is updated every nanosecond, basically. The algorithms that are used there based on experience. If we had similarly adaptive algorithms within the NHS, how do we regulate that? I mean, the impacts of some of these algorithms might be changing every second. So how do we assess and monitor? I'll just take another couple of questions, but then we'll return to some of the themes. So I think there's somebody here, and then somebody in the back corner. And Nick as well. Nick's got the microphone, so I think you.
Yeah, possession is very useful in this sort of thing. Nick Barber, UCL School of Pharmacy. I've been involved with 2 of the major evaluations of technology in the NHS, the rollout of the electronic prescription service and the rollout of electronic patient records in hospitals. And what we found was that a lot of the issues behind the scenes which aren't addressed really affect the future, and that's to do with power and ownership and secrecy in contracts. So one of the major systems in the USA actually has written into its contract in the USA that no one is allowed to do research on the system to show any problems with it. And we don't know whether that's the case with English contracts or not, where hospitals have taken that up. We also found that data is held in such a way that it would be very hard to transfer to another system. So as you became locked into a system, we found that people couldn't access records from 10 years ago because the system had been changed in which the way data was recorded, and then there needed to be an upgrade which they had to pay for to get to that record. And we found just power plays and awkwardness throughout the whole thing. So the risk with faster progression is that we get ourselves into a difficult situation. I just wondered what the bedrocks are that we needed to think about in this, exciting and rapidly expanding field.
Such a great series of questions, and there's a lot there about the contracts, but it sort of chimes with some of the things we've been thinking about at the Health Foundation about the commercial arrangements for data sharing. So we're seeing a lot of some NHS organisations sharing data with commercial companies to help with the development of new technologies and the evaluation of them. There's a lot of benefit that comes from that. But what is the transparency around these arrangements, and is the fair value for the NHS from data sharing? Would be one particular sub-dimension of that bigger question you asked. At the back.
Hi, Nikki Davey. I'm Clinical Human Factors Group and also a quality improvement person. Particularly to Neil, I think, and Romani perhaps as well. You mentioned, Neil, in your lab you come in and test these things, which is really great, and we certainly are trying to support and promote that kind of approach. When you get companies to come in and sort of use their kit to do that, how willing are you finding them to actually address problems which you might then surface? Because the incentives, the commercial environment that these companies work in means that, from what we can gather anyway, the pressure for them is for them to meet the regulation requirements, which are quite often quite poor in terms of the extent to which they actually reach the end goal for the patient. So they will jump through those hurdles, but anything else over and above that around usability for practitioners or for the end result actually is not loaded into the equation. So have you had any of those conversations where you found resistance or trickiness, or are you finding them all very willing to learn and do something about it?
Thanks. So, to address that one just first, as it was kind of directed, we don't know yet for many of the companies. One of the things that, though, we have noted that links really the 2 points together is around, you basically have 2 options when you're trying to do something with a commercial company. You either have to just suck up how they want to do it and then do something yourself on top, or you get them to do it. And there are potential advantages and disadvantages to each, but in fact, many of the electronic patient record vendors have their own proprietary data formats for everything, which means it's quite good for that particular thing, but you have to go through an intermediary to do something else. And actually, that was one of the things that we decided quite early on that we would have to take on. In other words, we don't want to do any customization at all. What we will do is spend a lot of upfront time making it so that we can take the output of what the company does into some sort of common language that you can then start to do other things with. Now, the difficulty with that is that's quite resource intensive, and it's particularly resource intensive up front. Now, the big advantage of that, though, is once you start to have data in some sort of common format, not only can you share it, but you can start to do interesting things with it. And there is a there is a format for healthcare data that some of you may have heard of called FHIR, which is a relatively new format that won't solve lots of problems, but essentially works like an API, which means that if you have your data stored in a FHIR format, in theory, anyone who would have access to that data set can write an app to do something with it. And in fact, that is the route that we are planning on going down a lot for customization of our system. So there are certainly some companies that we've already come across that do exactly what you say. They basically say, no, this is ours. If you want to change it, you can pay us lots of money to change it, but then you're locked into that. So the alternative is cheaper in the long run, but it does mean you have to put that effort in. And I just want to just quickly take the opportunity for your point about saying that it's no one's job. I think one of the issues is it's trendy now in health to come up with a recommendation, particularly if it's got AI in the title. So everyone's doing that. So lots of big recommendations about what everyone must do, but that's no use to any individual hospital or GP surgery because there's no additional resource, there's nothing for the people on the ground to actually do those things. So it's all very well saying we have a whole list of things now that we would like you to do. My point was, well, okay, but who's going to do that then actually on the ground? Because it's either going to be someone who's now doing something else, which we're going to have to stop them doing, or it's going to have to be someone new. And that may lead into maybe some other discussion about the whole thing of skills. Who are these people? How do we get these people to work in the NHS rather than somewhere else?
Can I maybe come back on that very briefly, Adam?
Yes.
Just about whose job is it anyway, and also about the adaptability of systems and so on. We, within the NHS and associated with the NHS, pay lots and lots of people a fair wage to do research. And what I don't really understand is why we're not paying lots and lots of people in a fair way to do innovation. Because at the moment, doctors who work within or nurses or healthcare professionals of any type who work within the NHS who have a great idea for a piece of technology or a new algorithm or anything else, what they tend to do is pursue the commercial option with that, and that's their route out of the NHS. And it's nuts, because the majority of research that goes on associated with healthcare is within the system or within the charitable system and so on. So the social enterprise model or many other systems could be used to both bring people with expertise and retain them within the NHS, because we do it already in research, so why wouldn't we do it in innovation?
I think that's a really interesting question. Maddie, do you want to have a go at the regulation? Oh, you're regulator, you're a company?
Yes. So I suppose, in terms of what do we need to do for a regulation, or in what way?
Well, how's the regulatory framework worked for you?
Yeah, I mean, it was about reaching obviously ISO standards, and we were lucky enough in Leeds. We've kind of got quite a nice and sort of happy environment really in Leeds. There's a nice ecosystem emerging, I think, within the city between two buildings really, the platform and Nexus at the Leeds University. There's quite a lot going on. And we were there's quite a lot of mentorship through both the ASHN and there's a company called We Am Habitat who talked us through this from kind of an early phase. So just literally when we had the idea, Dr. Fiona Campbell put us in touch with this lady who was a spin out, I think, from York. Yeah. But it is difficult because if you don't, there's a lot of happy accidents there, and actually there'll be a lot of people. I know there's people that want to do it but don't know how to start or didn't have those connections.
Comes back to the point about how it's very hard to navigate this.
Yes, I think whether it's the clinical safety or whether it's the standards or whether it's the evaluation. Patients don't necessarily, some might, will come with different skills, but they're not doctors and they're not clinicians. So we come with a different life experience. We come with the lived experience, And I suppose to kind of come back to that lived experience, I'd probably quite like to say that, I do sometimes feel, or have felt, that lived experience is undervalued in the system, and it's a huge commodity. You know, we live this every single day, and whilst I appreciate the idea of obviously creating innovation teams within the NHS, I've been invited along to quite a few kind of co-design sessions within the system, and I have felt kind of it's quite tokenistic. You know, you've been brought in for an hour, but the person or the team that have kind of are developing it have already got their idea about what they're doing, and they kind of want you to validate it in an hour, rather than actually thinking, well, this is the big problem, and you've got the condition, or your son's got the condition, and bring those young people in. You know, gosh, they've got so much good stuff to say. And they're built with technology kind of in their fingertips. They live it, you know, they've got all that lived experience as well. So when we've brought young people into the co-design sessions, you know, we wouldn't have had DigiBeat without the young people designing it. We didn't design DigiBeat, they did. So I think, you know, thinking around that, so I think probably there's an opportunity there for skilling up on both sides.
It's kind of a bit like we were discussing earlier around, there is this frustration by you as a patient are trying to do something that you essentially want to give away for free to patients. But you are forced to go down a commercial route because there's no way the NHS can support you to do that. For an NHS organisation, ideally you also want, there may be some that want to make money, but in general you also want to develop something that's good for patients and give it away for free to the NHS. But your own organisation will say that's no good because you're not making any money out of that. We have to somehow break that so that the system benefits, not everyone obsessed with everyone having to maintain themselves. And that's a real frustration, because you could easily have NHS organisations where everything, they support patient-led projects. It would be an easy thing to do.
Yeah.
I want to just squeeze in at least one last question before we have to wrap up because of time.
There's a lady over there.
Sorry, yes.
Hi, my name's Maddie. I'm from Allocate Software. I'm one of the vendors in this space. We do e-rostering software and medical scheduling software. So we've worked for many years trying to improve adoption of software products in the NHS, and because we believe that fundamentally it's about improving the workers' experience of work and trying to make sure we've got safe teams on the ground as well. So that's really where we come from. As a software company, we've done I suppose in the last 3 years, really a big push towards SaaS. So that's a term called software as a service, where it's saying, actually, guys, you know, you don't want the hassle of maintaining your servers and all those sorts of things. We'll do that for you. And that's been actually very successful. And I think the WannaCry incident was a massive wake-up call for lots of people in the NHS that said, actually, you know what, as we have, maybe it's not I don't think we can say that there aren't anyone whose day job it is. There are people who have this as their day job to support and enable and improve our technology within the NHS, but there aren't enough of them, and they're not skilled enough in what they're trying to do. So the SaaS movement is taking away that responsibility, and we were trying to be a better partner by doing out-of-hours upgrades, you know, your disaster recovery for you, your cloud, everything for you. And actually, after WannaCry, we realised we were helping those teams to be hollowed out. Actually, we were less of that sort of skill set, which we could do more of. So now, being a better partner now means that we should help those teams on the ground. This isn't in our contract. We're not doing it because we're paid to. We're doing it because it is better for the NHS if actually you can maintain those systems. You know when you have issues, how you can fix them. Or when you want to tell your vendors to shut down your system because you have a cyber security attack, you know how to do that. So we're really keen in empowering people. I suppose the question is, how can you ask vendors to do more, what you should be asking them for, and how can they help you in your innovation agenda?
Thank you so much. We're a bit pushed for time, but there's certainly a role here for industry. I don't think anybody would deny that. And there are some very interesting questions we haven't really been able to get into about what are the what are the sort of terms of engagement for industry, and how is industry focused, how could it be focused on the really big problems, addressing the NHS, how to handle the commercial arrangements, that kind of thing. But a really valuable point, thank you. I'm going to wrap up. I mean, I think some of the themes are about time. Whose job is this to do the innovation? How do we work together? How does the system enable a better innovation, particularly through more integrated care models and through changes to payment? I finally just wanted to flag up the Health Foundation's own work in this area. As you know, we have been supporting frontline teams to experiment and innovate with new ways of delivering care for some time. So do please look at our resources if you haven't already. Many of those projects are about technology. We also have a program of work on data analytics to help the NHS make more use of its data. And of course, social determinants are a very big aspect of this as well. You heard about some of that work this morning. We will now go into the breakout sessions, many of which build on these themes. There are, for example, there's one about data analytics, there's one about automation, there's another one more about the social determinants. Then we'll come back together at the end of the day for another plenary session about automation and what does this mean for the changing professional life of our clinical teams. I just want to thank all the speakers for your contributions, which were very insightful. Thank you very much.
Thank you.